Welcome everyone. Thank you so much for joining our talk today with Dr. Chughtai. My name is Jyoti. I'm the marketing manager here at UTIBA Health. And I also wanted to introduce my colleagues, Derek and Faraz. They're part of the team as well. So I'm just going to go over some quick housekeeping before we get into the presentation. So the presentation is going to run for 1 hour, and the first half hour will be with Dr. Chughtai covering the presentation. We'll then move into a Q&A. I'm sure you guys are going to have a ton of questions after the presentation. And then I also wanted to make sure that you are all adding your questions throughout the presentation within the Q&A box at the bottom here. So not the chat if you can, but the Q&A box, that would be very helpful. And we'll be keeping note of all the questions, and then we'll be sure to get through as many as we can at the end of the presentation. Following the presentation, as you all know, we are going to be doing a quick raffle, so be sure to hang on until the end. And then for anybody who is interested, we will cover some product information for the products that we have here at UTIBA. So if you're interested, just be sure to hang on until the end. So with that, I will introduce Dr. Bilal Chughtai. Thank you, Dr. Chughtai, for joining us this evening.
All right. Well, thank you, everyone, for the opportunity. Oh, well, Jyoti, are you?
I'm going to do a quick bio on Dr. Chughtai, just for anybody who's not familiar with him. So Dr. Chughtai, he completed his medical degree, followed by a residency in urologic surgery at Albany Medical Center. He's completed a 2-year fellowship in voiding dysfunction, neurourology, female pelvic medicine, reconstructive surgery at Memorial Sloan Kettering Cancer Center and New York Presbyterian Hospital in New York City. He is also currently an associate professor of urology and specializes in female pelvic medicine and reconstructive surgery and male voiding dysfunction. Dr. Chughtai maintains a deep longitudinal interest in these highly prevalent and debilitating conditions and has focused both his clinical, research, and teaching activities within these areas. Dr. Chughtai also mentors students, residents, and fellows in clinical and basic science research projects, which has allowed his team to be investigators in numerous clinical trials, as well as translational and outcomes research, including National Institute of Health and industry support. Finally, Dr. Chughtai has published over 2,000 peer-reviewed articles. He's authored chapters in several urologic texts, published 4 textbooks, and has presented numerous national and international meetings. So with all of that being said, again, Dr. Bilal Chughtai, welcome to this talk tonight, and we're very happy and excited to have you here.
Thank you, Jyoti, for that kind introduction, but I've published 200 manuscripts, not 2,000.
Oh, I'm sorry.
Someday I hope we get to 2,000, but not yet. All right.
Thanks for the correction.
So we're going to get started. We're going to talk about a quick, basically, management of overactive bladder, which I'm sure a lot of you are familiar with. And then we're also going to review a clinical trial that we did with a natural solution. So first, these are my disclosures. And this is what we're going to cover on our talk today. So we're going to go over some definitions, prevalence of overactive bladder. We'll talk about management, what are typical first-line therapies, including lifestyle, second-line therapies, pharmacotherapy, as well as third-line treatments, including neuromodulation and chemodenervation of the bladder with Botox. And we're also going to do like a deep dive into some special populations of talking about specifically the elderly population and depression. And then we're going to end with talking about the paradigm shift with a novel product with Flowens. So what is overactive bladder? So the International Continence Society defines overactive bladder as urgency with and without urgency incontinence, usually associated with frequency and nocturia. So there are a couple of key symptoms that we think about. One is frequency, the need to urinate. Usually patients describe it every hour, hour and a half. They know where every single bathroom is, but classically defined as greater than 8 voids in a 24-hour period. It's sudden. There's a compelling desire to void, difficult to defer. Urgency incontinence, which is the same thing as urgency, but then you have a loss of urine preceded by that urgency episode. And nocturia, which is defined by urinating more than 2 times a night. And one thing to keep in mind about overactive bladder is that as we see a lot of these patients with this condition, many patients, suffer silently, and they usually try to find, coping behaviors, and they're not aware of the fact that there's treatments that are available. Unfortunately, the condition, tends to be embarrassing. We don't really have a champion for overactive bladder or urgent continence, and so therefore a lot of patients will suffer an average of probably somewhere between 5 to 7 years before presenting to even the primary care doctor about their condition. And overactive bladder has many negative impacts on quality of life. This includes psychological impact. So a lot of these patients, feel depressed. They have a lack of motivation. Because ultimately they're worried about their dignity, as well as the fact that they have this debilitating condition. It can affect their work, their productivity, where they're spending a lot, frequent toileting. Also the economic burden of toileting products as well as pads. A lot of these patients can be isolated due to anxiety, fear, and fatigue. In addition to that, a lot of these patients will become less physically active. They'll avoid recreational sports, hobbies, travel, because ultimately they want to know where every bathroom is. Obviously, it's hard to be sexually active when you're concerned about having incontinence episodes, and again, affects things like ability to do activities of daily life, hygiene, as well as obviously if you have nocturia, it affects the quality of your sleep, which can have its own debilitating effects, as well as feeling, particularly, tired and exhausted the next day from lack of sleep. So who is affected by overactive bladder? I mean, we know that approximately 25% of both men and women experience overactive bladder symptoms, and about half of men and over half of women between the ages of 40 and 59 experience these storage symptoms of urgency, frequency, urgent incontinence. And when we talk about incontinence as a whole, there's a couple of different types, including stress incontinence, which includes leakage with cough, laugh, sneeze, mixed incontinence, but urgent incontinence and overactive bladder are the most common cause of incontinence in the elderly. And incontinence as a whole is one of the largest reasons for admissions into nursing homes as well. Now, there's urgent incontinence and overactive bladder can also be a marker of frailty, where patients who are more frail tend to have this condition. And in addition to that, a lot of these patients can have cognitive impairment from the debilitating aspects of like loss of sleep, as well as the depression and anxiety that can be caused from this condition. So when we're seeing these patients, we want to first obviously recognize these urinary symptoms. And as practitioners, we want to know how these symptoms are, their severity, their impact on quality of life. We want to conduct a physical exam, including a pelvic exam, to ensure the fact that there are not other causes of incontinence for these patients. You want to know the comorbidities, including diabetes, dementia, other types of cancers, enlarged prostate in men, prolapse in women. You want to know the current medications, because diuretics can definitely lead to changes in urinary function, where patients can have a lot more sudden urgency to urinate right after their medication. Consider doing a urine analysis to rule out conditions like hematuria, to rule out bladder cancer, as well as infection. And you want to think about other conditions that may lead to these symptoms as well. In my practice, for a lot of these patients, we consider doing bladder diaries. We also try to figure out, what their fluid intake is. I try to get some standardized questionnaires to understand impact of quality of life, and also establish a baseline that a lot of times as patients are progressing through the pathway, I can show them sort of like the progress that they've made. And you want to ask questions such as, hey, do you have any uncomfortable urges to urinate? Do you have a sudden urge to urinate? Do you ever have accidents of urine? Do you get up at night to urinate? And for all patients, we always want to implement first-line therapies, mainly because they are very low risk. There's no downside in doing them. And ultimately, a lot of patients can have a lot of progress. These include behavioral therapies, including bladder training, pelvic floor exercises, consider physiotherapy, and time voiding. These are and biofeedback. Time voiding is the idea of having patients urinate every 2 hours, 3 hours around the clock, obviously not when they're sleeping, but as an effort to reducing the amount of urine that's in their bladder. So if they do have an incontinence episode, they tend to be a lot smaller. And biofeedback is a great way for patients to learn muscle training as well. Consider lifestyle changes where you change the fluid intake. Like sometimes patients will say things like, at nighttime, I'll take my medications with a giant glass of water in efforts of, staying hydrated. And this makes me get up multiple times at night. You want to think about weight control. There are studies, we've done some in men looking at the correlation between waist circumference and urinary tract symptoms, where reducing waist circumference and weight can definitely reduce urgency episodes, urgent continence episodes in both men and women. Also, educate patients. You want to set treatment expectations. You want to provide information and resources. You want patients aware that, look, we're going to try a therapy, or we'll try some type of modifications. And if that doesn't work, there's pills and there's other treatments that we can get into. A lot of times, by patients being aware of the multitude of options that are out there, this really helps them understand that, look, this is a common condition, and there are a lot of treatment options. And you can consider other therapies, such as toileting assistance for elderly patients, meaning that, consider for older patients who have difficulty with mobility, you might want to think about like a bedside commode, or even consider devices like external catheters for some of these populations to help reduce incontinence episodes, or soiling of their clothes. So now we'll move on to second line therapies. These include basically pharmacological treatments. There's two big classes of treatments. There are beta-3 agonists and anticholinergics. The mainstay of treatment and the most common treatment in the US and Canada as well is going to be anticholinergics. Anticholinergics inhibit the muscarinic receptors. They prohibit the detrusor muscle contraction. And in addition to that, they also these receptors are located throughout the body. So a lot of times when we think about muscarinic receptors, especially the M1 through M5, there's other collateral impact, such as cognitive impact, as well as impact on the GI tract leading to constipation. And basically, it's the M2 receptor that's more sensory. M3 receptor is the one that causes the bladder to contract. The other class of treatment, which is slightly newer, basically the first drug to come out was mirabegron in 2012, and these are beta-3 agonists. They activate detrusor muscle relaxation, and they increase bladder capacity. And what's interesting about this class of drugs is that they don't interfere with the voiding process. So the bladder is still able to contract well. So rates of retention or rates of incomplete emptying theoretically should be a lot lower with beta-3 agonists, and we do see that in practice as well. And these receptors tend to be more localized to the bladder, but there is some cross-reactivity, some to beta receptors in the vasculature system that can lead to hypertension with some of these medications. But the one good thing, the one huge advantage beta-3 agonists have is that they don't cause dry mouth, constipation like anticholinergics do, nor do they have a risk for dementia. And again, pharmacological treatment is recommended in combination with behavioral and lifestyle modifications. So when we look at anticholinergics, they actually have a variable adverse event profile, meaning that if we take a look at a lot of the drugs that are out there, this includes oxybutyn, salfenicin, talteridine, we can see that a lot of these drugs end up having anywhere between 1 to 5 adverse events, and this includes things like dry mouth, constipation. So in some ways, when you're solving the problem of overactive bladder or helping to alleviate it, sometimes you're causing other issues. And some patients, when they get more dry mouth, they'll end up drinking more fluid, which defeats the purpose of the medication and causes more urgency and frequency. Or sometimes with constipation, they'll try to drink extra water to try to relieve the constipation. So a lot of times when you're using these medications, you want to make sure patients are aware of the potential side effects and consider things like a xylitol candy for dry mouth, or consider a fiber supplement for constipation, as opposed to them increasing fluids. And when we talk about treatment persistence, I think this is like really fascinating data, because when it comes to overactive bladder, we know that irrespective of medications, and even when you look at the newer drugs like beta-3 agonists, we can see that a lot of patients quit using their drugs within a very short period of time, probably somewhere between the first 3 to 6 months. And a lot of times patients will stop drugs due to adverse events or due to lack of efficacy. it does seem that, in some of the data that we look at, that the beta-3 agonists seem to have better tolerability and better persistence, likely due to their side effect profile. But even then, they can still have about a 50% drop off over the course of a year. And just quickly, just want to go over some third line therapies, just so that we have a comprehensive understanding of the array of therapies available. So first one is Botox. Botox basically leads to a blockade of the neuromuscular junction, therefore sort of like paralyzing the bladder. So this is sort of a good therapy for carefully selected patients. And big side effects to think about for Botox are retention. So those who already have incomplete emptying, you can worsen their condition. Those who have any reason why they have issues with their outlet could have even more trouble emptying their bladder as well. The other one is side effect is urinary tract infection, which occurs about 7% of the time. There's peripheral tibial nerve stimulation, which is basically using neuromodulation at the posterior tibial nerve above the medial malleolus. It is safe. It has about a 2/3 efficacy rate, but keep in mind that this requires very frequent visits to the office, about 1 visit a week for about 3 months, and requires touch-ups. So either a treatment a month for 12 months or 4 treatments in a row every 3 months. Then the last treatment is sacral neuromodulation, which is at the S3 nerve root, where basically it's done in 2 stages. Stage 1 is either done in the office or in the operating room, where a lead is placed, electrical lead is placed near the S3 nerve root, and it's then connected to an implantable pulse generator. It's probably the most invasive of the third line therapy. But it's a therapy that works well for those who are refractory to other treatments, but does definitely require a 1 to 2 visits to the operating room. And these devices last, the new treatments probably somewhere around 7 to 10 years. So they do require revision surgery after that. The older devices used to not be MRI safe, so a lot of times these patients couldn't have MRIs, but the new devices that are implanted now are MRI safe. So that exclusion no longer exists. Now, just focusing back onto the treatments for overactive bladder. So just focusing on the frail and the elderly. So one thing to keep in mind is that when we're talking about medications as a whole, both beta-3 agonists and anticholinergics, as we get older, we don't process medications the same way. And a lot of times these randomized controlled trials, these are very highly selected patients that typically only have a single condition, and usually there's age exclusion in a lot of these trials where those that are octogenarians are no longer included. So there can be changes in pharmacokinetics, absorption, distribution, and clearance of the drug. And sometimes these drugs can build up in the body, and you may have to pace out the drug or dose it in a way where it's less frequent than typically prescribed. Also, when it comes to polypharmacy, so a lot of times, we know how a single drug may interact, but sometimes these patients will be on 10 to 15 medications. At that point, the risk of adverse events increases exponentially with each additional drug. And even though a drug on its own may seem pretty safe, once you combine it with a whole elixir of other medications, it can become quite challenging, and you can end up with some adverse events as well from that alone. You want to think about anticholinergic burden. So think about using like a Beer's criteria to sort of come up with a cumulative use of these medications. And, cognitive impairment is something that's very real, especially in the older population. Adverse events tend to be higher in this population as well, because again, anticholinergics are associated with sedation, heat intolerance, delirium, and falls. But keep in mind that when it comes to anticholinergics, it's usually the earlier generation and the less selective ones. And lastly, when we're talking about this population, a lot of them can also have, challenges with communication, including, difficulty with hearing, and you want to tailor your communication to the patients, and sometimes even involve caregivers if necessary. It really helps enhance the care of these patients. So just to go into a deep dive of anticholinergic burden, This is basically the cumulative effect of multiple anticholinergics, and it can lead to negative health outcomes in older adults. So firstly, older adults sometimes will forget over-the-counter medications. Sometimes they'll forget supplements as well. They do tend to be more sensitive to anticholinergic side effects. So you want to think about the risk versus benefits of these medications to minimize burden and prevent things like, falls, constipation. And you also want to think about doing a anticholinergic scoring. So basically looking at medications that definitely cause delirium, those that could have clinical evidence of anticholinergics, and in vitro. But a lot of times using modern EMRs, it's a way for us to sort of like track this. But I think as practitioners, it's important for us to sort of keep this in the back of our minds, especially when we're prescribing drugs for those on multiple medications, especially those that are older and maybe forgetful of other medications that they're on. And when we talk about the elderly population, their pharmacokinetics, and in addition to things like even like the blood-brain barrier could be less intact in some of these older populations. So there'd be an increased risk for things like dry mouth, blurred vision, constipation, cognitive decline. And when we look at the EAU guidelines, they specifically state that long-term anticholinergic treatment should be used with caution in elderly women, especially who have pre-existing cognitive dysfunction. And anticholinergic burden and associated comorbidities should be assessed in patients being considered for treatment of overactive bladder. And when we talk about dementia, there's been a number of reports linking anticholinergic medication to cognitive impairment and an increase in incidental dementia diagnosis and possible increase in mortality. And when we look at a study published in 2018 of about 40,000 patients aged 55 to 99, we found that antidepressants, urologic, anti-Parkinson drugs with an ACP score of 3 are linked to future dementia incidents. And a lot of times when I mention a risk of any cognitive impairment in patients, they become very reluctant about the use of anticholinergics. And unfortunately, in the US, anticholinergics are typically the ones that are covered by insurance, while the more modern beta-3 agonists tend not to be covered as well. So going back to OAB, in a lot of ways, we know that this condition has tremendous impact for the patient. Patients can be angry with themselves, angry with their bodies. They get frustrated. They get worried, like, hey, what's going on with me? They get anxiety. They feel embarrassed about what's happening. And they sometimes do get, hopeless about their overall condition and burden. And a lot of times they'll end up becoming more isolated about this. So it's important to ask patients about symptoms of overactive bladder, because we know that it can have a tremendous impact on a patient's quality of life. And when we look at other comorbid conditions, we know that depression can affect approximately 1/3 of these patients. Now, it's hard to say if overactive bladder patients are depressed because of their pre-existing condition or how these are exactly how they're correlated. But I think the important thing to keep in mind is that a lot of these symptoms tend to coexist, and about over 30% of patients with overactive bladder do report depression with their symptoms. So it is an important condition to ask about and treat. And those with overactive bladder and depression tend to have more incontinence episodes and more severe incontinence episodes. So when we look at this more closely, about 1/3 of patients who have clinically defined depression, 10% of these report severe depression as well. But the more important part about this whole thing is that we're seeing that a lot of these patients tend to have higher rates of urgent continence episodes, and therefore have a higher impact in their overall patient-reported outcomes. So ultimately, when we see these patients with incontinence, we know it can have huge impacts on psychologically and their overall well-being. And when we look at clinical impact papers, how patients have described their symptoms, a lot of these patients will describe their symptoms as like, incontinence they rate as a state almost worse than death. So we know it can have tremendous impact on these patients. And lastly, when we look at mental health, we know that both depression and anxiety can have negative impact and prolongation of urinary symptoms. Many patients prolong treatment-seeking behavior due to embarrassment, which delays initiation of treatment management strategies. And poor mental health can also lead to poor compliance, lack of memory. And in addition to patients who have nocturia, poor sleep, can also have difficulty remembering their treatments and algorithms that you talked about. So in a lot of ways, these are self-fulfilling prophecies where worsening symptoms cause more mental health impact, and then this can lead to more challenges and poor outcomes when you're managing patients with overactive bladder. And patients with overactive bladder also end up adopting a lot of behavior to cope with their condition. And this can also have, tremendous impact where, they have a hard time remembering other things, where they're trying to reduce their fluid intake, therefore leading to poor oral hygiene, higher rates of urinary tract infections, higher rates of constipation. They're spending lots of money on incontinence pads, which tend not to be covered by insurance. They're carrying around a fresh set of clothes and pads just in case they have an accident. They're avoiding intimate situations so that they don't have incontinence episodes, and they're constantly planning escape routes so they know where every single bathroom is. And a lot of times when you inquire from these patients, they'll tell you things like, "I know where every single bathroom is, and in my city or in my town, I know where I could stop on the side of the highways where I don't have to worry about I can squat and use the bathroom there." And they also limit their travel to places where they know where they can get frequent toileting as well. So again, just to summarize, managing overactive bladder, you want to recognize the symptoms and its tremendous impact on quality of life. You want to apply the appropriate assessments. You want to educate the patient, set realistic treatment goals, and help the patients take ownership of their treatment. You want to initiate behavioral and lifestyle therapy and add pharmacotherapy if required. And you want to follow up frequently with these patients, because sometimes if you don't follow up, sometimes patients go, maybe that's all I have and this is me and I've got to live with this forever. You want to modify the treatment if necessary. So now we're going to move on to the exciting part of the talk, which is really focusing in on a novel option. So in my practice in New York City, I see lots of patients who are always inquiring about, is there something natural? Is there something else that you can do? So one of the things that we did is we reached out to actually a company, NatureX, who produces a cranberry supplement. They had some promising data that they showed in male LUTs, or male urinary symptoms, and ultimately showed like it did change some bladder capacity and compliance issues. So we decided that this would be a unique opportunity to see if this could help in overactive bladder. So the compound itself is basically a dried cranberry, and we studied this in basically women who had dry overactive bladder, so those who did not have incontinence episodes. And we published this approximately like a year and a half ago. So Flowins is basically, it taps into the growing consumer demand of a non-pharmaceutical natural solution. It's produced by sustainably grown cranberries and is sold with an ID pack to help validate botanical identity. And as we all know, that when it comes to supplements in the market altogether, there's a lot of supplements out there with some wild claims. But the thing that's good about Flowins is that we know that it's validated, and we know it's pretty standardized as well. So just to go into the study details, we basically screened 118 patients, randomized them to the study. We basically included 25 in the placebo arm and basically 33 in the per protocol analysis. And what that means is that ultimately, out of all the patients that we did the study on, and as for those of you who are very familiar with clinical studies, you know how hard compliance can be. And sometimes a lot of these patients did not complete the diaries, but ultimately, we still were able to get the study completed and it was powered. So just to go over I know this is a lot of numbers and we're going over here, but ultimately when we look at the per protocol and the total those who completed the study, we can see the cohorts are very, very similar altogether. We see that basically they're well matched between treatment and placebo. When we talk about changes in micturations between week 24 and baseline, we see that the daily micturitions basically dropped by 2 in the cohorts. And when we look at urgency episodes, they had a drop by almost 4. When you compare this to other anticholinergics as well as beta-3 agonists, this is on par with medications. When we looked at patient-reported outcomes like OAB short form, PFDI-20s, patient perception of bladder health altogether, these were all statistically significant differences in showing a reduction in the number of urinations per day, in addition to the bother that patients had with their condition as well. Now, when we look at the intent to treat analysis, which basically includes all the patients that started in the study, we still see that between treatment and placebo, there's a reduction of about 1 void per day, and daily urgency episodes reduced by almost 1.5 per day. So ultimately, patients, irrespective of how you look at the analysis, had a tremendous impact. And I would just draw your attention now to table 5, where we looked at cranberry versus mirabegron, talteridine, and salfenicin. And you can see that when we look at the micturition difference, ultimately this cranberry, the Flowens product, had a reduction by almost 2, matching that of salfenicin and better than that of the other treatments as well. And again, when we compare it to placebo, this is on par with the other medications as well. So it's pretty impressive that for this double-blind randomized controlled trial that we saw that cranberry was on par with these other medications. So from this, we're able to conclude that the daily intake of dried cranberry improved daily micturition, urgency episodes, patient-reported bladder condition, and supporting its use as a safe treatment for overactive bladder. So going back to our OAB treatment spectrum, obviously first-line therapy is lifestyle behavioral changes, weight reduction, reducing caffeine, bladder training, stop smoking, limit fluid intake, especially towards the evening, and time voiding. Then you go on to anticholinergics, beta-3s, think about neuromodulation as well as Botox, and then obviously last line therapy is surgery. But I think, based on this randomized controlled trial, we see that Flowens definitely fits a very nice niche right here, where it's got a tremendous safety profile, much better than anticholinergics, and probably better than beta-3 agonists. And it's got data that's very compelling as well. And ultimately, it's probably one of the least invasive therapies that we can offer these patients. So just going to summarize our overall talk. OAB is prevalent, affecting almost 12 to 18% of men and women of all ages. It can have a negative impact on well-being, quality of life, physical health, and there are a multitude of pharmacological and non-pharmacological therapies that are available. And Flowens has extremely promising randomized controlled trial data for OAB symptoms, potentially offering it for patients who have this condition. Thank you.
Thanks, Dr. Chughtai. That was a great presentation. We have tons of questions, so let's just get right into it. So the first question that I have here is OAB different? Does OAB present differently in men compared to women?
Yeah, so that's a great question. So in a lot of times, I think as urologists or as doctors as a whole, we tend to blame men's prostates for all their problems, and women, we tend to blame their bladders. But when we look at the overall condition, the symptom complex is actually very, very similar. You have urgency, frequency, urgent continence, nocturia, which is how OAB presents in both men and women.
Okay, thank you. Next question, can beta-3 agonists be used in patients with glaucoma?
Yes, so there's no contraindication for both open angle, closed angle glaucoma. So when it comes to the anticholinergics are contraindicated for those with closed angle glaucoma, which tends to be the least common type. But at the same time, when it comes to beta-3 agonists, they have tremendous safety in that domain. The biggest issue with beta-3 agonists is that they can affect blood pressure. So that's something you do want to check on these patients.
Okay. What are the similarities, if any, between IBS and OAB?
Great question. So I'm not an expert of IBS, but I would say that a lot of the GI conditions, there is this sort of like bladder-bowel connection, and those who tend to have more bowel symptoms tend to have bladder symptoms. And a lot of times, if you improve one domain, you can definitely improve the other domain as well. So a lot of times for these patients, if they're having significant GI symptoms, I'll definitely work closely with a GI doctor so we can address both conditions simultaneously.
Okay. How often are first-line lifestyle modifications truly effective?
Yeah, that's a good question I get from patients all the time, where a lot of times they'll come in and they'll go, well, I drink this much fluid in a day, and do I really have to do this? Do I have to really get rid of my favorite, like coffee, tea, wine, whatever it might be? But I would tell you that in a lot of ways, like I tell patients that it's an awareness list, not a punishment list. Like, I'm not here to take away your favorite coffee or your favorite like drink, but at the same time, just be aware that sometimes these things can lead to significant symptoms. And sometimes I am surprised by how much of an impact it can have, or the level of improvement these patients can get by simply reducing the amount of fluid intake that they have, especially towards the evening.
Yeah. Okay.
So bottom line is, I offer it to all my patients. And if you're going to ask the second question, which is what is the compliance, I would say not the best.
Okay. Or maybe for a little bit and then they stop.
Very common.
Okay. So next question, how does tibial nerve stimulation work for OAN?
I'm sorry, could you repeat that question one more time?
Yeah.
Sorry.
How does tibial nerve stimulation work for OAN?
Yeah, so I assume they mean OAB.
Yeah, OAB. They
Yeah.
wrote OAN. I wasn't sure if that was maybe an acronym I wasn't familiar with, but OAB.
Yeah, so sacral nerve modulation, so neuromodulation works by the methodology, and the way that posterior tibial nerve stimulation works is that you're putting electrical stimulation that retropulses up the posterior tibial nerve and goes to the S3 nerve root. And when it goes to the S3 nerve root, it modulates the nerve to help like create almost like a crosstalk. And this crosstalk helps reduce urgency episodes. And obviously, because it's a weaker signal, you're only doing it once a week, the efficacy is around like probably around 60%. So I tell patients that we're going to try this for about 6 weeks. If we're not seeing much of a benefit, then at that point, we'll probably think about doing something else.
Okay. Is pessary used for OAB?
Yeah, so pessaries have a multitude of uses. So pessaries can be used for urinary symptoms that can be from prolapse. So if you have a bladder that's herniated into the vaginal area, by supporting the bladder, you can sometimes restore some of its function. Pessaries can also be used for stress incontinence, where it can reduce, put pressure on the bladder neck and reduce leakage that occurs with cough, laugh, sneeze. And pessaries can also be used for prolapse to help reduce the heaviness or bogginess from that herniation that can occur. But they're typically not used for overactive bladder. It's typically used for prolapse, but prolapse can present with urgency and frequency as well.
I see. Okay.
And that's why it's important for us as practitioners to do physical exams so that we know that a patient has a significant prolapse contributing to their symptoms.
Okay, thank you. If one considers discontinuing an anticholinergic drug, do they have to be tapered down?
No, so these drugs can be started and stopped whenever whenever you want. The problem with these drugs is that you typically want to build a layer, I would say it takes a while to get the effect. So when we talk about a beta-3 agonist, typically trials need to be around 4 to 6 weeks to see a difference. So it's you don't necessarily have to taper the drug, but it does take a while, and you do have to set that expectation that if we're doing an anticholinergic or beta-3, it takes around 4 to 6 weeks to see a difference.
Wow. Okay, good to know. So next question: does Myrbetriq, for dosing for Myrbetriq, how many weeks after initiating 25 milligrams by mouth once daily do you follow up with the patient to assess efficacy?
Yeah, so I usually do the 4-week mark. So 4 to 6 weeks, we will do something, either a televisit or we'll do an in-person visit to talk about expectations and to also talk about improvement. And if they don't have adequate improvement by the 4 to 6 week mark, at that point, I'll double the dose to 50 milligrams.
Okay. And would you do that 50 milligrams at once or split it between 2 doses?
Yeah, so typically it's for up once. So I would say the most common dosing of mirabetriq is um, is 50 milligrams, right? But I would say for some of the older populations and sometimes those with polypharmacy, I'll start at the 25 milligram. And for that population, we'll go from 25 and we'll double up to 50.
Okay. Is the active ingredient of the dried cranberries D-mannose? Have you looked at D-mannose specifically?
Yeah, so that's a great question. So active ingredient of cranberry is not D-mannose. When it comes to cranberry and overactive bladder, we don't really have there's a couple of different theories of how cranberry can impact the bladder and the sensory web of like that urothelium, but it's a mechanism that's not well described at the moment.
Okay. So what is the relationship of OAB versus prolapse causing urge incontinence? You did speak a little bit about this earlier when we were talking about the pessary. Is there anything in addition you wanted to add?
Yeah, I mean, I think prolapse is a little bit beyond the scope of our conversation here, and definitely we could do a whole talk on prolapse alone. But when it comes to prolapse, ultimately, what can happen is that there's a couple of different reasons why you can end up with urgency frequency. One could be when the bladder herniates outward, it can kink the bladder neck, and that could lead to incomplete bladder emptying, and therefore you get urgency frequency. It can also just be the fact that the bladder doesn't. Biggest reason is incomplete emptying can lead to urinary symptoms, but prolapse and overactive bladder can also coexist as well.
Okay. So next question here. How long to see improvement with flow-ins?
Yeah, so in our trial, I've had patients on flow-ins for up to 3 months after initiation, but a lot of patients had persistently good outcomes starting from like the 4-week mark up to 3 months. Ultimately, we don't have long-term data, but if you look at a lot of the overactive bladder trials, they'll have short, they'll have outcomes for 3 months, and we believe that if it worked for 3 months, it should work for much longer.
Okay. Okay, could you expect the same results with any 500 milligram cranberry?
Well, that's excellent question. And I would say that unfortunately, when it comes to the supplement market, and that's why we talked about what made Flowins kind of unique, is that cranberry comes in a wide variety and not all cranberries are the same. So as a result, we don't know if other cranberries have the same compound processed the same way and would give you the same sort of outcomes. We specifically picked Flowins for this trial, given its unique properties and the fact that it's pretty standardized. But we don't know if that's true for other cranberry compounds.
Okay, thank you. So next question here, in relatively younger patients, say 50 to 65 years old, what percentage of OAB sufferers have urinary frequency / urgency compared to the number of patients with urinary incontinence?
Yeah, so I would say that a lot of times when you see younger patients, they do what they can to cope with the situation. So they'll do things like change of clothes, pads, they'll have escape routes, they'll have things to help avoid incontinence episodes. But I would say it's typically when you start seeing these patients having difficulty with mobility, cognition, other conditions start to set in like depression, anxiety, that's when you start seeing larger and larger amounts of incontinence episodes. But you do see patients who are younger that can have incontinence episodes as well.
Okay. Let's see here. Okay. Are B3 agonists, beta-3 agonists, helpful when a woman has prolapse that is causing urge incontinence? Can you see, again with prolapse, can you see prolapse in an ultrasound?
Yeah, so typically prolapse is a physical exam. So you would do a pelvic exam on the patient, have them bear down, and then from there you can typically do some type of assessment of it, and you can see like what's sort of herniating down. Is it more bladder, bowel, apical prolapse? But it's really a physical exam. Imaging has not been used very much in the diagnosis of prolapse, but there is some novel data on the use of imaging and helping to sort of come up with treatment algorithms for prolapse as well.
Okay. What medications can be used in children suffering with OAB?
So when it comes to data on children, we know that there has been studies with anticholinergics, but we know that it can have cognitive issues. Beta-3 agonists, I'm not sure if they've done, so I'm not a pediatric urologist, so I'm not that familiar with like the pediatric data, but I do believe that the beta-3 agonists have some data in the pediatric population, or they're in the process of doing those trials right now. But anticholinergics I know have been used for a long time in that population.
Okay. Is there a maximum dose cranberry? Any idea how it works? I think they're referring to blow-ins.
Yeah, so with flow-ins, we use the 500 milligram dosing. We never did a dosing study per se. That was the 500 milligrams dosing was actually selected based on the male study. And there was a male study done I believe in Europe. And that study basically showed improvement with a 500 milligram dose. So that's why we did the same sort of dosing for women as well.
Okay. Is OAB more related to depression or anxiety?
Yeah, so when it comes to OAB, we see a correlation, and between the correlation, we see both depression and anxiety, and those conditions tend to overlap as well. I haven't seen great studies that tease out if it's more correlated to one over the other, but typically those two conditions tend to coexist too.
Yeah, that makes sense. So what is the basic pathophysiology of OAB? Is it inflammation?
Yeah, another good question. So we don't know. I mean, when it comes to overactive bladder, we know that it's a condition that gets more common as we get older. We see it predominantly more in women than we see it in men. There's a lot of theories behind it. There's theories behind, talking about how we tend to have more sympathetic responses as we get older, and we have overall more inflammation. There's theories on how microbiome could play a role in it as well, but we don't have a clear-cut like it mechanism.
Okay. When is it appropriate to refer to urology for a patient with OAB?
Yeah. So when it comes to overactive bladder, if it's a patient that has urgency, frequency, urgent continence, and you've done a physical exam, right? Assess for things like prolapse, and you've done an analysis and culture to rule out blood, white cells infection, and you've got no other comorbid condition, I think it's reasonable to try medication. If a patient has a failure of a medication, I think it's worth starting the conversation of, hey, do you want to try a different medicine, or go to a urologist about potential, other second line or third line therapies. For patients who have, other comorbid conditions like recurrent infection, blood in the urine, those are patients that you want to refer sooner than later. Actually, almost right away, to make sure there isn't other condition going on.
Okay. What is the highest dose you have used with Myrbetriq?
50 milligrams is the highest I've used.
Okay. So along with UAN pelvic ultrasound, do you recommend getting a bladder ultrasound with PVR before treating a patient?
In my practice, I do get PVRs before starting treatment, but I think for a patient, when we look at the overactive bladder guidelines, it's not unreasonable to start medication if you don't have any reason to believe that the patient has high amounts of residuals. So in other words, if you have patients who have comorbid neurologic condition, if you feel a palpable bladder on exam, those are patients I would definitely think about getting a bladder ultrasound first. But otherwise, you're probably pretty safe to try a medication.
Okay, thank you. Do you ever prescribe both mirabegron, I don't know if I'm saying that correctly, excuse me, and an antimuscarinic together for OAB in the frontline setting versus trying one of the options first?
Yeah, so I will typically start one medication at a time. So I will start, typically I'll try like a beta-3 agonist. We'll try that for 2 to 4 weeks. If a patient has some improvement, then we'll have a discussion about the role of third line therapy versus combination therapy. Now, currently it's off label in the US, but there've been plenty of studies done showing the showing the use of combination therapy, and it's approved in Japan, it's approved in other countries. So I'll tell patients it's off-label, but it's something for us to think about trying a combination. But I'll usually do one medicine, then add on the second.
Okay. What is your opinion on using DDAVP for nocturia?
Yeah, so when it comes to nocturia, there's probably 4 common causes. Things like sleep apnea, we know, can cause nocturia, poor sleep can cause nocturia, overactive bladder can cause nocturia, and there's nocturnal polyuria. For nocturnal polyuria, DDAVP is probably the mainstay of treatment. And DDAVP obviously comes in doses. It's a medication that has its own side effects, such as hyponatremia. But for those who have nocturnal polyuria, it works really well for them.
Okay. Is it possible to purchase and use a TENS unit at home for posterior tibial nerve stimulation instead of going into one's healthcare office?
Yeah, so when it comes to posterior tibial nerve stimulation, the needle, so TENS is a muscular stimulation. It's not typically stimulation of the nerve. So when you're doing PTNS, you're actually putting a needle, and that needle is putting electrical stimulation not directly, but pretty close to the nerve. And the goal is not to stimulate the muscle. So ultimately, a TENS would not be the same as doing PTNS. But there are some novel therapies that are coming out that look at potential external ways of delivering that signal, but I haven't seen anything out yet.
Okay. So this one, it's off topic, but it's come up quite a few times in the Q&A. For recurrent UTIs, do you prescribe low-dose antibiotics or cranberry tablets?
Great question. So when it comes to recurrent UTI, I think that's a talk on its own. And again, it's there's a multitude of ways of addressing it. Then, I mean, from hydration, the use of cranberry, topical estrogens, but I typically follow the AUA guidelines for how I manage recurrent UTI.
Okay. Is the efficacy of Flowins enhanced when used together with second or third line treatments? Or are Flowins sufficiently efficacious when taken as a sole OAB treatment?
Yeah, so when it came to the clinical trial, these patients were ones who were not on anticholinergics, they were not on beta-3 agonists, and these were patients who were only on Flowins. So we don't have data on how these patients would do with combination therapy. Now, ultimately, I mean, that might be another potential use for it, but we don't have clinical data to support it at the moment.
Okay. I understand that the data research regarding supplements and vitamins is limited, as big pharma cannot typically benefit from their sale. Who is interested in funding, supporting, and leading these cranberry-related studies?
Yeah, so this was actually supported by the manufacturer of Flowins, which is Naturex. So I would tell you that classically that is true, where it was hard to find funding, but I am finding that there are companies that are looking to provide, who are looking to make clinical data and support the use of certain supplements or combinations. And it's great to sort of see that, because there's huge patient demand for it. And I think as we're seeing more and more people in this space, there are both manufacturers, I think providers and patients who are looking for higher quality data to support the use of these supplements.
Yeah, it's good. It's good to hear that for sure. Okay, let me see what's the next question here. Does taking cranberries and or anticholinergics affect bowel movements?
So in theory, cranberry we had very few GI side effects. I think there was like one patient that had some upset stomach, but anticholinergics haven't, definitely one of their known side effects are causing constipation.
Okay. So we're going to cover 2 more questions just in the interest of time, although we have a lot, quite a few still to go. So one of the last 2 questions, would you recommend a UDS for a refractory OAB prior to sacral neuromodulation?
Yeah, so in my practice, when we're getting to third line therapy, I do I definitely offer urodynamics for all my patients. Those that have elevated post-void residuals, those that have particularly slow flow, those are ones that I'll definitely get urodynamics for, because I'd want to know how to differentiate them for, neuromodulation versus Botox.
Okay. And final question, let's see here. There's just so many. Can Flowence or cranberry be used for IC as well?
Don't know. So in the study, we excluded those with bladder pain, so we don't know. But when it comes to treating IC, we know there's multiple components. There's pain, there's sexual dysfunction, and there's urinary symptoms. For those that have a strong OAB, strong urinary component to it, I don't think it's unreasonable to try. The thing to be careful of, though, is that with any of these, with cranberry, it can sometimes make the urine more acidic, and some patients could be more sensitive to it. So again, we don't have clinical data on that population, but I think for those who have, less pain, more OAB symptoms, it could be something to at least discuss with your patients.
Okay, good to know. All right, so we're gonna end it at that. Thank you, Dr. Chughtai, for your time and for your presentation and for answering all of these questions. And I really hope the audience enjoyed it. I know I learned a lot myself.
Thank you. And thank you for the opportunity to present this research as well.
Of course, of course. So thank you again. And oh, hi, Derek.
Hey.